Thank you, Mr. Chairperson. So, I've been asked to talk about the changing paradigm in the type 2 diabetes management. I'll be discussing about the changing concept. It's not simply A1C lowering. We are heading towards the physiological based therapy in the management of diabetes. And the second is that whom to are treating and what should be our target for achieving glycemic control. So we are talking about the patient-centered approach, and that is based on the background information of what is the epidemiology and healthcare impact, what is the relationship of glycemic control to the outcome, and an overview of pathogenesis of type 2 diabetes. And then we'll discuss briefly about anti-hyperglycemic therapies, what are the glycemic targets, and what are the therapeutic options. And then we will talk about how to implement these strategies, initiate drug, then we'll advance to dual combination or triple combination, and then shifting the patient to insulin therapy, especially if the duration of diabetes is more than 8 or 9 years. And we have to have the other consideration for age, weight, and what is the comorbid condition that the person is having. Now, the patient-centered approach means that before you start the therapy to any individual, you have to know that how much involvement of the patient is there, what are the comorbid conditions that the person is having, what is his seriousness towards the disease management, and you explore all the possibilities. Before you write the prescription, you must know how much money the person is having in the pocket. There is no point of asking to take DP4 inhibitor to a person who cannot afford even few rupees for the tablets. So you have to have a decision before you start prescription, and that decision has to be shared by the patient. So this is based on the background. You know already, I'm not going to tell what is the problem that we are all facing as far as the prevalence of diabetes is concerned. And now these are the landmark studies. You all know that UK-PDSC study that was done in type 2 diabetes. You have DCCT, that is in type 1 diabetes, published in 1993. And then there was extension studies, what you call as the EDIC studies. Now these are the landmark studies that have shown clearly that a good glycemic control can reduce or postpone microvascular complication. Then you have got 3 landmark cardiovascular studies, ACCORD, ADVANCE, and VADT, and an attempt was made in these studies to almost normalize A1C. And you see that, no doubt, achieving a very tight control in diabetes will reduce microvascular complication. But in terms of macrovascular complication, most of these studies have shown that there is no benefit. In fact, this is going to harm the person if you are making a very tight control as far as the glycemia is concerned. So I'll touch briefly about the pathogenesis of type 2 diabetes. You all know that basically previously about 20 years back when I was a student, I used to be taught that there are 3 major core defects in diabetes. One is beta cell dysfunction, another is increased production of glucose by the liver, and third is there is insulin resistance at the adipose and muscle tissue. Now you have got, you know that you have got about 7 or 8 defects, and each and every defect they contribute about the pathogenesis of diabetes. So therefore your therapy has to be physiological based therapy, not only intent of lowering A1C. So say for example you have got the defect, what you call it, either there is incretin resistance or you have got incretin defect. You know that incretin is a polypeptide hormone that is secreted from the intestine, and it stimulates beta cell to produce more insulin in a glucose-dependent manner. It also reduces the glucagon level. Then the other thing is that you have got the defect in the adipose tissue. You have got also problem with the alpha cell. There is increased production of glucagon, both in the fasting state as well as in the postprandial state. And then you have got the effect in the level of the brain. What you call as that there is insulin resistance at the level of hypothalamus. You also have got, it's not shown here, the defect in the kidneys, you know that SGL2, and these are contributing to the pathogenesis of type 2 diabetes. So what will be the anti-glycemic therapy? One is that you have to have a glycemic target. That means as per ADA recommendation, A1C should be less than 7%, and that means mean plasma glucose of 150 to 160 milligram per deciliter. And preprandial should be less than 130, and postprandial should be less than 180. But it has to be individualized. That is the key issue, and that is the changing pattern of diabetes management. You have the tight target if the person is young, if the person is healthy, and if the duration of diabetes is very short. If the person does not have cardiovascular disease, target is 6 or 6.5% is good. It should be less than 6.5%. But if you are treating a person who is 60 plus, who has got long history of diabetes, who has got comorbid condition, you have to have the looser target, something like A1C of 7.5 to 8%. And you have to keep in mind the problem of hypoglycemia. So this is what we call as patient-centered approach. On your left side here, you can see that what is the attitude of the patient, how much the patient is interested in listening to the treatment and curing diabetes, how much he is reliable. So if the patient's attitude is good, and if he has got short duration of diabetes, if he have got long life expectancy, if there are no important comorbid condition, if he does not have any established vascular complication, if you have got resource system, support system, I will prefer to maintain A1C of less than 6.5, at every cost less than 7%. But if the person is less motivated, you can see on your right side, if the person is less motivated, he is not very reliable, not very particular about his disease care, and if his duration of diabetes is very high, long duration of diabetes, if he has got short life expectancy, has got comorbid condition, and has got established vascular complication, the A1C should be anywhere between 7.5 to 8%, and not inviting hypoglycemia in these individuals. So that is what we call as the patient-centered approach in the management of glycemic management of type 2 diabetes. So what are the therapies available? You all know therapeutic lifestyle will always insist, difficult to implement, but will always insist and request and every visit to the patient that please keep on doing some lifestyle modification activities. As far as possible, try to optimize the weight, healthy diet, and increase the activity. So the therapeutic options which are available, you know that these are all drugs which are available. On your left side, we have got these oral medications like metformin, sulfonylureas, thiazoline, dienediones, DP4 inhibitors, GLP-1 receptor agonists, and SGL2 inhibitors, which has recently been approved. And on your right side, we have got meglitides, which I think most of us don't use, alpha-glucosidase inhibitor, not a very good option because many people they are not able to tolerate. And again, this is basically postprandial drug, and it's a bit quite costly also. Then we have got the bile acid sequestrants, not very friendly, we are not using most of us. Then we have got dopamine 2 agonist. You have heard the name of bromocriptine. I have never prescribed anybody to bromocriptine because I don't know. A1C lowering is hardly 0.5%, less than 0.5%, and this drug is not efficacious. And then we have got amylin mimetics. Again, they are injectable and not very popular in most of the places. So I'll briefly touch some of these things. So the metformin, there is no doubt, you all know that it activates cyclic AMPs. And the good thing is that this reduces the hepatic glucose production. Advantage, we have got extensive experience, no hypoglycemia if the drug is taken alone. It's a weight neutral drug, and there are some of these studies which have suggested that CV events can be lowered down. Particularly, UKPDC studies has very clearly shown 18% reduction in the cardiovascular disease. Disadvantages there is some of the people they develop gastric intolerance, and it's written lactic acidosis. I have not seen any case of lactic acidosis, and I don't think in this country, as far as India is concerned, not more than 2 or 3 cases of lactic acidosis has been reported, and that too we are not very sure that whether they were actually the cases of lactic acidosis. So if you choose metformin in the subject who does not have any evidence of hypoxic condition, I don't think this drug is going to give lactic acidosis at all. Some of the people, they do have B12 deficiency, so if they complain of diarrhea or something like that, you can add a small dose of folic acid and that takes care of. The cost is very low. And the other good thing is that A1C lowering is very good, 1.5 to 2% A1C lowering. Then the sulfonylureas, you all know that it closes the KATP channels, increase insulin secretion. Of course, we have got extensive experience, and it decreases microvascular risk. And you must have heard so many articles that there is increased incidence of cardiovascular disease with the use of sulfonylureas. The data has still not been settled. You first started with the fenformin, but still there are some studies available that incidence of coronary artery disease is more if the person is taking sulfonylureas. And out of all the sulfonylureas, what the current data shows that is published recently, it is the glyclazide which is probably safer than your glimepiride, safer than the glipizide. And of course, the most of the reported cases of coronary artery disease, they are the cases with the glibenclamide. So out of all the sulfonylureas, whatever the current data says, probably glyclazide is the better drug as compared to the glimepiride, glipizide, or glibenclamide. Disadvantage, of course, it will give rise to hypoglycemia. There is always weight gain of 1.5 or 2 kg. Low durability. Whatever the studies are available, the durability of maintaining A1C is hardly 1.5 to 2 years. There is some doubt of ischemic preconditioning, but that is not the issue with the glyclazide. Cost is low, that's one of the advantages. Then we have got thiazolidine diamonds. It activates PPAR gamma, increases insulin sensitivity. Good thing is, it does not give rise to hypoglycemia. Durability has been tested for 3 years with the rosiglitazone and pioglitazone. So it can maintain the A1C durability for 3 years. Some of the concern about the increased incidence of postmenopausal osteoporosis with the use of pioglitazone. So if you are prescribing the drug in the postmenopausal female, it's always better to assess for the osteoporosis. And if it is there, it is always use the anti-osteoporotic drug along with this compound. There is no problem. The cost is obviously high. Alpha-glucosidase inhibitor, I have told you, it's a lot of GIT problem. A1C lowering is hardly less than 0.5%. So it's not a very preferred drug. Then we have got DP4 inhibitors. It inhibits DP4, you know already. It increases the endogenous GLP-1. Advantage is there is no hypoglycemia. It's a well-tolerated drug. Disadvantage is moderate A1C lowering, something like 1.3%. The cost is very high. Then we have got GLP-1 receptor agonist. It activates GLP-1 receptor, increases insulin and decreases glucagon, decreases gastric emptying, and increases satiety. The advantage is weight loss. So if you are having obese type 2 diabetes, and if we manage to accept this injectable drug, it's better to prescribe GLP-1 receptor agonist rather than DP4 inhibitors in these individuals. The disadvantage is, of course, the GI side effect, 5 to 40% incidence of nausea. But if you just continue the drug, most of these people, they are able to tolerate the GI problem. Not very established data for increased incidence of pancreatitis, and the same thing is true for medullary carcinoma of the thyroid. The cost is high. 1 month treatment costs about 7,000 to 8,000 rupees in this person. Then I will not talk about amylin mimetics and all these 3 drugs, because I say that most of us, we don't practice this drug. And then we have got insulin. And you know that it activates insulin receptor, it increases glucose disposal at the periphery, and insulin also decreases the hepatic glucose production, one of the core defects in pathogenesis. Advantage is it is universally effective, unlimited efficacy as far as the lowering of A1C concerned. The disadvantage is, of course, weight gain. And weight gain is something about 2.5 to 5 kg if you are putting the patient on insulin. And of course, there is always disadvantage of drug produces hypoglycemia. And the other thing is also the increased incidence of coronary artery disease. You know the data are coming if you treat a patient with insulin therapy. The cost is variable. So, and what are the therapeutic options as far as the insulin is concerned? You know all these insulins which are available. And here if you see that you have got two types of insulin available. One is human insulin and the other is analogs, what you call as designer insulin. There is not much difference between two types of insulin except that the analog insulin or designer insulin is more convenient because you can take just before meal or even it can be taken with meal. So you don't have to wait for half an hour or 45 minutes because these are all monomeric insulin. You inject the insulin and insulin is absorbed within 5 minutes. The other advantage of the analog is there is less incidence of hypoglycemia as compared to the human insulin. And third is there is slightly better efficacy as far as the A1C reduction is concerned. Now, if you are taking human insulin, regular or intermediate acting insulin, you have to inject 30 or 45 minutes before because these are the not monomeric insulin. When you inject it, they have to be converted into dimers and then monomers, and that conversion takes about half an hour, 45 minutes. So disadvantage is that the person has to wait at least half an hour, 45 minutes before he is allowed to take breakfast, lunch or dinner. So that's all. Otherwise, for me, both the insulins are same. Their efficacy is not much different, except there is increased incidence of hypoglycemia with the human insulin. So how to do that? So best thing is that when the diagnosis of diabetes is concerned, and we of course will insist and request the person to stick on diet and lifestyle modification, and we'll put the patient on day one with metformin, and then we'll just wait for about 2 or 3 months and see what is his A1C lowering. And if his A1C is more than 7%, we have 2-drug combination. And here, as for the ADA recommendation, you can have the addition of sulfonylurea, the thiazolidine diones, or DB4 inhibitors, GLP-1 receptor agonists, or you can have the basal insulin. And you can add now that you can also have SGLT2 inhibitors. So these are the what you call as 5 options. If the person is not able to control with the metformin, you can have this combination. And the other is that if the person is not able to control 2-drug combination, you can go to 3-drug combination accordingly. And ultimately, if the 3 drugs are not able to have, then you have to left with no choice except to put the patient on insulin. Now, as for the insulin is concerned, there are 3 or 4 regimes. And the basic thing is that if the person is already taking 3 oral hypoglycemic drugs, and if you found that A1C is not able to, you are not able to achieve the target A1C level, it's better to start with the basal insulin. Though the recommendation is said that 3-drug combination A1C is less than 9%, put the patient on basal insulin, and if the A1C is more than 9%, put the patient on prandial insulin. But it is always better that if you start basal insulin, moment the A1C is as close to the 7 as possible, because if you are adding basal insulin at this time, you are just trying to avoid weight gain, which is invariably occurs. And the other is that if the basal insulin is not able to hold it, you can start with the prandial insulin. You have to make another recommendation is that you have to have your target, less ambitious targets, I already told you, is 7.5 to 8% if the condition that I have mentioned are there. Similarly, the other condition is comorbid condition. So metformin is always choice, coronary artery disease, sulfonylurea, I have already told you. I have already told you about the other problem that these patients they face. Similarly, the patient is heart failure, there is some concern with metformin. You can prescribe, but you have to see that how much liver damage and hypoxemia is there. Avoid thiazolidine damage. I'll take half a minute, sir. And if there is a liver dysfunction, there is a query about incretin-based therapy. Similarly, if there is renal disease, you can prescribe metformin in the full dose if the GFR is more than 30, but if the GFR is less than 30, you can just reduce the metformin to less than half the dose. And similarly, if there is liver dysfunction, most of the drugs not tested in advanced liver disease, pioglitazone may help with steatosis, and insulin is the best option if disease is severe. So, of course, in hypoglycemia, you have to make concern what are the drugs that you have to choose. So, this one, the last slide, that the recommendation is A1C is less than 7%, but it has to be individualized, and pre-prandial, post-prandial blood sugar should be maintained, as I mentioned here. Blood pressure should be less than 130 or 140 by 80, and LDL should be less than 100, and HDL, accordingly, if you are able to maintain HDL, and triglyceride should be less than 150 milligram per deciliter. Thank you, sir. Thank you very much.
Thank you.